I think it works with every other fluid as well. So you inject these 20 milliliters of contrast fluid slowly because you don't want to blow up the vein. And then you can check and aspirate and see if you're still in the vein, if there's blood coming back into your butterfly. You put a small pressure bandage on when all the contrast fluid is in. And then, so the original standard protocol from Rick Redden said 6 X-rays per foot. I just do 5 because now from the 0 degree view, I don't see too much information. It's hard to shoot that proper. So I normally do 5 X-rays. Then I do the lateral, so the 90-degree view, the 0-degree view, so AP. And then the same on the unloaded foot, because you want to see how the blood vessels do at the sole area. And then you put the horse back on the block and shoot another lateral and DP view after 2 minutes to see with how the vessels look like if the foot was unloaded in between and is then loaded again. So if you need at least 3 people, and if you're practicing a little bit, it's done quite quickly, and it gives you a lot of information about horses with laminitis. Even if you can see the changes or get your diagnosis in a normal X-ray already, you can give a way better prognosis about the time that it will take the horse to get back to a normal and healthy foot. So if you injected your contrast fluid, then normally there's 7 points where you have to look at if you want to check the venogram. So in these slides, I just put the lateral view, and because we don't have too much time. So the first thing you have a look at is the tourniquet area. Is your tourniquet working, or is your contrast fluid already proximal of the tourniquet? So then you look at the heel region. Normally, we do not have too many problems in that area in laminitic horses. So you look at your vessels, look at of the contrast. The next thing you have a look at is the coronary plexus. So that's the part which is normally bleeding if you inject the coffin joint. So you have a look at the coronary plexus, if there is still blood flow going through or if it's completely blocked already. You look at the dorsal sublamellar plexus, so at the dorsal wall of the coffin bone. A severe laminitic case is more or less completely black here. Then the next thing you have to look at is the circumflex vessel, so the tip of P3. If you have a severe rotation or thinking, you can see that the vessels are pushed upwards when the bone is changing, that they are all twisted in that area. You always need to have a look at the blood vessels at the sole. If they have a very thin sole or the bone is going that direction already, you can imagine that these blood vessels are a lot under pressure and getting compressed a lot. So you can see exactly which part of the sole you need to take the pressure away to allow the horse that the blood is still going all around the foot and the foot will still grow. And the last thing you need to have a look at is the terminal arch, so the other way the blood is going into P3 and around. So this is also something you need to check at your venogram. And this is more or less the 7 points you need to have a look at if you do these venograms. So what can you find? The typical findings in the venogram, if you focus in a little bit more. So if you've done a proper job, then you can even see the lamellae structure in the dorsal part. What we saw in the beginning, the lamellae, the primary lamellae fill with the contrast fluid as well. So you can see exactly which direction is the foot growing. You can also see these papillae and lamellae at the tip of the bone. So that's the direction your foot is growing over the lamellae. And what you see in a severe laminitic case is that these lamellae structures are bent upwards, are pushed upwards, and are twisted. And that's a typical finding you can find in the venogram. Why to do the late picture, the picture after 2 minutes? What you see here is that there's some of the contrast fluid going out of the vessel. So that's a sign for an acute inflammation, and that there is some leakage in your blood vessel system. You get these jets. So this is a sign for acute laminitis for sure. Some examples, what you can find in venograms. What you see here is like compression of the sole. You can see that the blood flow here is blocked, and then the horse has too much pressure when it's standing with the weight on the sole in that area. Next thing you could see in a severe laminitic case is when the horn capsula is pushed upwards into the soft tissue on top of the coronary band. The horse is blocking its blood flow itself. So not only this diffuse leakage down the tip is a problem, but also what you could see here, the capsula is pushing upwards, blocking their own blood flow. So when you come into this circulus vituosus, so the lamellae dying more and more because there's no blood going in there. So you've got more rotation and thinking, and then it's blocking it even more. So you have to take the horse out of this circle, because otherwise the situation will get worse and worse. The chance of healing is quite bad if you don't even have any blood reaching the part of the foot that you want to medicate or treat. What you can find as well, especially in a really chronic laminitic foot, is pictures like these. If you look at the dorsal lamellae here, for example, you can see that the foot is growing that direction. So what they get is these typical shape of the dorsal wall, because the capsula is pushed upwards against the bone. The lamellae are bended in that direction, so the foot is not even growing in the correct way. So also you could see that there's a lot of changing at the tip of the bone. You can see that all these vessels are bended, and you can also see that there's a lot of compression at the solar area. So just some examples what you could diagnose on a venogram, and like I said, it's not that complicated to do that. You can even do that in the fields if you've got people enough and an X-ray machine with you, and quite a good diagnostic tool for laminitic horses. Hello, let's come to the therapy. When we diagnose our horse laminitic, we have to treat it as well. And especially acute horses needs quick treatment. So acute laminitis is always in an emergency. So the faster you start your treatment, the better the outcome of the horse will be. So it sounds very easy. Delete the trigger factors, treat the cause and not only the symptom, manage the pain, and stop the ongoing destruction of the tissue. Sounds quite easy. Unluckily, it's not. If you come to the chronic stage, then we will talk about the orthopedic trimming and shoeing as well, and about the long-time management. First thing is cooling. Put them in ice. Laminitic or the changes in the lamellae is an enzymatic process, and if you cool down the feet really a lot, like put them in crushed ice, you can slow down the enzymatic activity in the foot and prevent the ongoing separation between the lamellae and the hoof capsula. Otherwise, or as well, it reduces the pain. It just has an anti-inflammatory effect. And the foot needs less oxygen and glucose. If you cool it down, you don't not have any negative effects. They made studies where they put the horses in crushed ice for 5 days continuously, and it was absolutely no damage of the foot visible, and like Icelandic horses running through the ice all their life, and they don't get a problem either. So what you have to do is like put it at least to the carpal joint in ice. So what I normally do is just cut some trousers, put it around the leg, fill it completely with crushed ice. So really cool the feet down a lot. It just helps in the acute phase, so it will not help anything about the chronic changes, but against the inflammation and about the ongoing separation. So in the first 72 hours, you should totally cool down the feet. These 72 hours start when you eliminated the main trigger. So if you have a septic horse, you have to treat the sepsis as well, of course, and your 72 hours of icing go on like after you deleted the main trigger or after you cured the maybe metabolic reason. So a lot of ice is for sure a good thing for most of the laminitic cases. Second step is decreasing the pulling of the DDFT and take away the pressure of the dorsal wall under the sole. So like we said, the pulling of the DDFT when the bone is not in position anymore is the main problem we have from the biomechanic and orthopedic side. So you have to decrease the pulling in an acute phase of the laminitic. So the easiest thing is to wedge them up, put them on a wedge, so the way of the DDFT is getting shorter. The angle around the navicular bone is getting less. So really wedge them up like 20 degrees maybe, or 15 degrees, wedge them up quite high so that the tendon has a more straight way to the bone and is not pulling too much on the bone anymore. There are some studies about that. I just copied the article in here. So what you want to do is decrease the pulling and put all the weight back more on the palmar plantar side of the foot. You could do that quite easy with different tools. You can use these hoof boots. You can do which have angled inlays. You can also put a frog pulser in there to give the chance to the horse the chance to put more weight on the palmar part of the foot. You can build something yourself and angle it, or whatever you find and whatever your possibilities are. Just make sure that you lift up the heels to decrease the pressure. And of course, you have to give some medication as well. So what I normally use is still phenylbutazone acid and some acetylsalicylic acid. So these are the most common drugs for acute laminitic horses. If you have to give the horses the painkillers for more than 5 days, then I would switch to furocoxib and not give phenylbutazone more than 5 days. Especially the ponies sometimes could get colitis or severe gastric problems. So always after 5 days, you should switch to furocoxib. There's still discussions about ACE, acetylpromazine, which is making a vasodilatation. You don't want that in the acute phase, so I'm not using ACE in acute laminitis. And also the discussion about heparin or fragmine is still going on. So there's no real evidence-based study that it's helping the horse a lot. So I'm not using these either. I'm using some acetylsalicyl, okay, but not the heparin and fragmine. If you have really severe painful horses, you can also go to ketamine, lidocaine, butorphanol, whatever is working. If you have to manage the pain in a really painful laminitic horse, these are the drugs I normally use. One new or more or less new type of medication you could use are these SGLT2 inhibitors like vilaglufizine. So they presented that at BIVA, I think 4 or 5 years ago already. So especially in these metabolic cases, you can use that drug that makes the horses pee out the glucose. Right now, we do not have a registered drug in Germany, so we have to use the human medication. We do not have too many experience and long-time studies with these type of drugs, but I think we will use them quite frequently in the next years for sure. So this is something for the future we will use a lot for sure. So acute laminitis treatment, we said cooling, decrease the pulling of the DDFT. take away the pressure of the sole area, which is under compression too much, and manage the pain with the drugs we're talking about. So if it comes to chronic laminitis, our main goal of treatment is to try to get back to a normal physiological hoof, to derotate the coffin bone and the capsula, to make the horse walk sound without any pain medication. And the best way is, of course, to get the horse back to work again. Not all severe laminitic horses get back to work a bit, for sure, but should be the goal of the treatment. So the main aspects of trimming and shoeing a laminitic horse is still decreasing the pulling of the DDFT, bring back the breakover point and the center of rotation. We will have a closer look at that, and normalize the palmar angle. So if you look at the normal trimmed foot, in the left picture, all the blue parts is where the horse is standing on, and maybe some horses stand, barefoot horses a little bit more on the flock as well, but this is the areas normal physiologically the horse is touching the ground with. So in the right picture, this blue area is where you can put a lot of weight on in a laminitic horse without any ongoing destruction. So try to bring as much weight as possible at the frog, at the palmar part of the foot, and try not to put any pressure on the red part, so not on the dorsal wall, not on the area where the tip of P3 is next to the bone. So if we talk about shoeing a laminitic horse, we have to make a little excursus in shoeing and farriery. So a normal front foot of a horse should be square. So the distance from lateral to medial should be the same than from the center of the frog then to the most dorsal part of the foot, which is touching the ground. So in this picture, the red line ends here because this is an orthopedic shoeing already, because there's a grinded edge in the shoeing already, like we see it in a lot of sport horses. So this is the most dorsal part touching the ground, and then you've got a square, healthy foot. If you want to shoe a laminitic horse or give some advice to a farrier to shoe a laminitic horse, you should have a look at the hoof mapping a little bit, which is making life a little bit easier if you have these basics with you. So if you draw two lines from the base of the frog, just two straight lines, then this is normally the part where the nailing should be. That's what the farriers learn. That in this part of the foot you put your nails in. And if you draw the next lines and draw the diagonals from this part, then these diagonals should hit right here, and that's where your center of rotation is. If we have a look at the X-rays later, you will see what that means. So if you draw these diagonals, they should hit the widest part of the foot right here, and that's where the center of rotation should be and where you have to find it. If you look from the side and you draw a line from the dorsal part of the coronary band all the way down the coronary band, you can divide these distance into different parts. So like you see in these pictures, it's the same line here. And if you just put it in half, so half of the distance from the dorsal part to the palmar part of the coronary band, if you go here, then you will be at the level of the navicular bone. If you divide it in thirds, then if you look at the first third, like here, you will come down at the here, the red line, you will get your center of rotation. So if you look at the condyle of P2 and take the middle of that condyle, that's the point where the foot is turning. And if you draw a line straight down in a well-shot, healthy horse, then there should be as much shoe in front and behind of that line. So right here, when you see that broken hoof pastern axis and the flat negative angle, then this shoe needs to be positioned way more palmar than than it is now. And especially in a laminitic horse, where you've got a lot of problem in the dorsal wall and on the tip of P3, then the shoeing should be maybe even palmar than the center of rotation than in a healthy horse. So that's one thing you should have a look if you examine a horse with laminitis. So draw it in that picture again. That is your point of the center of rotation. If you go down and if you're well-shod horse, then it should be 50-50 shoe in front and palmar of that. So if we come back to the laminitic horses, they should be shot even palmar of the center of rotation. So from this perpendicular line, you try to put more weight on the palmar part of the foot. So the center of rotation is reaching the widest part of the foot. Good. Example for shoeing laminitic horse. Chronic laminitis. So we do our normal measurements we were talking about. We've got an angle of rotation of a little bit more than 8 degrees. We've got a palmar angle of more or less 16 degrees. We still have 10-15 millimeters of sole depth. So it is a chronic laminitic foot, but let's say not too severe, and something where we could work with, where we have some distance here. So we have the chance to shoe that horse around the center of rotation and put all the weight back. So at some point, I'm not a farrier, but I started trimming and shoeing horses myself originally because I was annoyed by waiting for the farrier, so I started doing it myself. And one thing you could do as veterinarians as well is using these wooden clocks. Originally invented by Steve O'Grady and published in I think 2009 first in the in EVG and EVE, and then were some follow-up articles. And I'm still using these clocks a lot because they give you the chance to make the horses very much more comfortable in like with 1 or 1.5 hours work, and you don't need to wait for the farrier. You can use these shoes yourself with a little bit of practice, and I would totally want you to use these shoes as well. So what you do is you grind the dorsal part of the foot and also the heels a lot. So you can if you grind the heels, and you can put a lot of pressure in that area. And what you do then is you screw into the foot. That sometimes not too good when the owners are around because they look a little bit scared if you start using a screwdriver on the foot of their horse. But I screwed a lot of these clocks and never hit some part of the foot I didn't want to do. So it is quite possible. If you learn that, they always say you have to do it like that, like drilling into the white line. I drilled into my hand a few times, so I started doing it that way, and it also working perfectly. And if you drilled your holes, you can take your clock, put a frog polster in there, so the horse is able to put a lot of weight in that part of the foot. Then you make your horse stand on that clock, and you just fix it with the screws. You can angle it like a little bit more if you want to. If you want to take away more pressure from the DDFT, you can just grind the polster, change your angle. You can grind the shoe heel a little bit more to take away the pressure of the dorsal wall. So this is something absolutely every veterinarian who is using podiatry or working in podiatry can do himself as well with a little bit of practice. So in our example, I just put these clocks on. I trimmed the heels a little bit to an angle of more or less 7 degrees. So if you just trim the heels to normalize the palmar angle, then you would even increase the pulling of the DDFT. So you have to angle your shoe minimum the same angle than what you grinded away on the heels. I shortened the toe a little bit, so the breakover is a little bit easier for that horse. And also there's some airspace under the tip of P3, and you just fix it with the screws. And just you will see that immediately the horse will walk away much better. So if you look at that horse, for example, just after 4 weeks, when we took off the shoes again, sometimes I'm leaving them on for 6 or 7 weeks either, you've got a nearly normal palmar angle. You suddenly have 18 millimeters of sole depth. So not the risk anymore that the bone is sticking through the sole area. And even you can start derotating your coffin bone and make the foot more parallel again, so it is growing back in the correct direction. This is just a picture after 4 weeks. So after 4 weeks, I sent the horse to the farrier and asked the farrier to put a rocker shoe on, or a Sapus shoe, so self-adjusting palmar angle shoe, whatever you want to call it. So it's following the same biomechanic principles. You give the horse some decreasing of the DDFT, so you have to wedge it up a little bit or like rocker it a little bit, gives the horse still the chance to put more weight on the palmar part of the foot, and shift all the weight as far palmar as possible, so to not have any pressure on the dorsal wall, and to give the horse the chance to lean back and put all the weight here, so you can see how the horse is improving and is walking much better after a few days or weeks already. So one thing you have to think about is this is not the end of the treatment. So just because the horse is walking better, it doesn't mean that the dorsal wall is suddenly stable again. Whatever died here, whatever lamella is gone, will not recover. It will grow out, and what you have to do is make sure that the new horn is growing in the direction you want to, but you will not reactivate the died lamella in this part. So be careful that even if the horse is more comfortable or even sound, that it is not start walking too much or even starts riding too early. So always remember that the foot is taking 9 months, sometimes even 12 months to fully recover and fully regrow. So this is always a long time treatment. Always be careful that you don't exercise these horses too early, even if they are way more comfortable with these shoeing quite early. So just small case report. I brought you as well, like the treatment of a severe laminitis, and sometimes even with these shoeing, even with these trimming, even with the wooden clocks, you're not successful. So not all horses respond to your treatment like you planned it, and this is one of the cases where we had to do the next step. So this was a case of a 15-year-old mare, which was presented originally with a really big wound in the neck. And so she has a quite severe sepsis and became laminitic because of that endotoxin shock, probably. For sure, she was also too fat. So like in the most cases, several trigger point coming together. So if you see a horse like that with an X-ray like that, where the bone is nearly sticking through, and especially when you've got very rapid clinical changing and radiological changing, and even horses which do not respond on your trimming and your shoeing, you sometimes get to the point where you need to do the surgical treatment. And the surgical treatment of the DDFT is quite risky, because what you have to do is cut the deep digital flexor tendon, so you can derotate the coffin bone quite rapidly. But of course, if you cut the DDFT, you've got the risk of a subluxation of the coffin joint. You can hit the tendon sheet, or I don't know, too many problems you can get with these surgery. But sometimes it is the last chance you have for these horses. If euthanasia or cutting the DDFT are your only last possibilities, then for sure cutting the DDFT is something you could try for these horses. What you need to tell the owners that there's a lot of risk in that surgery, and that also there's no prognosis for these horses as a sport horses anymore. So this horse she's now sound in walk, luckily, but she will probably become a breeding mare or and not a ridden or sport horse anymore. So if you look at that case, I tried it with the Stewart clocks in the first place, which was working quite good on the right foot, but the left foot didn't respond to that treatment the way I wanted to. So just 3 weeks later, after I put the clocks on, she came back with a really pushed up coronary band. So she was also sunken and rotated. The tip of P3 was nearly gone through the sole. So we had to decide very quickly if we do the surgery. So we did the surgery quite the next day. So what you have to do then, you need to have a good and experienced farrier for sure, which is able to do his part of the job. So we're trimming the heels back completely. So trimming the heels as far as you can. So you get the sole outside of the cuffing bone parallel to your shoe. So you can rotate your cuffing bone, bring it back into position, take out a rotation, and straighten your flat axis. If you would have trimmed the heel just like that, and then without wedging it up back again, or without cutting your teeth, then the bone would be through the sole in minutes, probably, because you increase the length of the DDT so much. So you put on a shoe, and normally what you do is fix it with two nails, make control X-ray, see like the position of foot, and if it's good on the X-ray, then the farrier can fix the shoe a little bit more nails. There's all the nails in all of glue. You can fix also glue the shoe as well, quite good. What we did here is we put an extra block under the shoe to take away all the pressure of the DDFT for the surgery. So wedge it up that high that the DDFT is really quite relaxed and you can feel it under the skin. Then you, of course, have the horse well sedated. You've got your local anesthesia of the nerves and also of the skin. You take a cut on the lateral side, high mid cannon. So you want to cut under the attachment of the accessory ligament, but not that much distal that you come close to the tendon sheet. So mid cannon is one of the described locations in the books. The other location would be down here, which is, in my experience, way more risky. You have to do it in general anesthesia, so the acute laminatic horse has to stand up from the general anesthesia. You've got your tendon sheet around here, so I absolutely prefer this region. We can do the surgery standing, just on a sedated and blocked horse. So you put your tourniquet around, make your incision on the lateral side of the higher level of the DDFT, like 3 or 4 centimeters. Better make it a little bit bigger so you can clearly visible the tendons. So you preparate a little bit into the deep until you can see DDFT, SDFT, and your suspensory ligament. If the horse is positioned like that, so really wedged up a lot, then you do not have a lot of pulling on the DDFT. So normally you can just take it out with some forceps or whatever bended surgical instrument you have. So you can, if you're sure you found your DDFT, you can take it out a little bit to the side and then cut it. After you cut the DDFT, you remove the block and the extra wedge we have here. And if you have a look in there, then you want to see both parts of the DDFT, and you can check that you cut it completely, and then there's a gap like 2-3 centimeters between the two ends of the DDFT. If you're sure you cut it completely and hopefully you didn't cut anything else, you can just close the skin and put some pressure bandage on, and then the surgical part is done quite quickly. So the shoeing takes much more time than the surgical part normally. The shoeing afterwards, what I normally do is not just the pressure bandage about the surgery part. What we normally do is we put a little bit of an extension plate on the palmar part of the foot, because if your DDFT is cut and your coffin bone is not does not have any support from the palmar side, the chance of the luxation or subluxation of the coffin bone is quite present. So this little extension should help that the foot is not flipping upwards and is not subluxating the bone. And then we just put some cast layers around to stabilize the shoeing and the plate a little bit more, because the horse should not step on the plate as well. So just put around some cast material. If you have a horse where the bone is stuck through the sole already, you can fenestrate your cast in front here, so you can still put some iodine swabs or disinfectant swabs or whatever in here, so you can still treat the sole if necessary. And that horse, the sole was still closed with you, so we didn't do that. So afterwards, you put your horse on pain medication and give it some box rest for sure. And if you look at these pictures after 2 weeks, you could see already that the bone on the sole area is growing more and more. And after 3 months, we could go back to a straight shoeing just with a little bit wedged up heels. You can see that the defect she had is growing out more and more. So the part which is growing from the coronary distally is strong and healthy. So her defect is growing out. I'm quite happy with this horse right now. She was just here for shoeing yesterday. She's sound in walk. She's happy. The wound looks good. So I'm very pleased about that case. So right now the foot looks like that. She's on a aluminium shoeing now. Still no pressure on the dorsal wall. Still the shoe is pushed back much caudally behind the center of rotation. I did an ultrasound of the DDFT the last time she was here, so the DDFT grows back together in 3 to 4 months. Of course, it is a lot of scar tissue you will find, but it is growing back together. And like I said, the horse is sound now. So this surgical treatment is, if you did not succeed with the conservative treatment, this is for sure one surgical option you as a vet should have and could use together with some experienced farrier. The complete case report with a lot of more pictures and explanation of that case will be published in the next Farrier's Journal next month. So you can have a look there maybe and see more information and details about that horse. And that's the end of my presentation. So these are the papers, books, articles I mainly used for the presentation. I could totally recommend these. Greetings to Mr. Rick Redden, one of the big pioneers in laminitic. He was the first guy doing a venogram. He was the first guy cutting a DDFT, and with over 80, he's still managing laminitic horses at his little farm in Kentucky. So for sure, one of the big pioneers when it comes to laminitis.
Recording stopped.
Thanks a lot, everybody. I hope you could learn some new facts about laminitis today. I hope you understood everything well. And if there are some questions, I'm totally happy to try to answer these.
Thank you very much, Dr. Bjorn Fries. I'm gonna read a couple of questions. Tenemos un par de preguntas para el Dr. Bjorn. Entonces, la primera pregunta fue, ¿por qué es más riesgoso hacer la cirugía cuando hacen el corte del tendón en la cuartilla que en el metacarpo? The first question, Bjorn, is why is it more risky to do the pastern approach uh, with
Yeah.
sedation instead of the cannon bone approach for the DDFT tenotomy?
Mainly because, so first of all, it's from the technical side, it's a little bit more complicated in my experience, and you have to go through the tendon sheet, so you're way closer to synovial structures, so your risk of infection is way higher than if you do it mid-cannon. And like recommended in the literature that you do that in general anesthesia, and letting a horse stand up with acute laminitis after surgery is also quite risky. And if you do the lateral approach mid-cannon, you do not have any synovial structures you have to go through, so the risk of infection is mainly way more under control.
Thanks. Tenemos otra pregunta en el chat, ahí la pueden leer, del doctor Wilfrido. The next question is, after an acute laminitis without rotation in a racehorse, what will be your approach for a rehab? And how long do you think it will be good to wait to return to work in a racehorse?
Yeah. So in acute laminitis, like we said, acute treatment of cooling and that stuff, and all that. If all that is done, the horse is sound again. So, and you do not have any big bony changes. So my advice would to do a venogram, see if there's really everything fine with that foot, if you have a normal blood flow in the foot, and if the foot is growing normally and you do not have any signs of an acute inflammation anymore, then I guess the horse can go back to work quite fast. I just had one case of a dressage horse with an acute laminitic after corticosteroid treatment, and he went back to work just 2 weeks later. So of course, in a racehorse, I maybe would wait a little bit longer because the pressure is a little bit higher. But if you do not have any bony changes and the acute phase is gone, you don't need to wait for too long.
Thanks. Tenemos otra pregunta del doctor Simón Lua, que nos escucha desde Colorado. The other question, Dr. Bjorn, is from the things you mentioned, soft ride boots, pads. What do you recommend in the acute phase, no rotation, to give some support to the hoof, besides all the medical therapy? And also, when will you decide if a surgery is needed, the tenotomy of the DDFT?
So in the acute phase, I'm normally using these soft ride boots, especially when the horses come to the clinic and I'm not here. Then my colleagues always use these soft ride boots in the beginning. I'm not a big fan of casting acute laminitis, which we still see a lot because all the icing and cooling is getting much more difficult if you put casts on. So that's why I don't like casts actually. So, like I said, normally I'm using the soft ride boots with the angled inlay. They are available in different sizes and not too expensive, and you can reuse them as often as you want. So we always have a stock of all the sizes in the clinic, and then we use the soft ride boots in the acute laminitic phase. But I tried to put the Stewart clocks on quite early. So after 2 or 3 days, normally already, I put them on the Stewart clocks then. Yeah.
Thanks. Otra pregunta, esta ya no es tanto de laminitis, es más relacionado a internados en el hospital del Dr. Bjorn. Dr. Bjorn, another question, not much related to laminitis. Students or young vets are asking if you can take internships at your clinic. If you can talk us a little bit about that.
Yeah, sure. We offer extern and internships. So externs from all over the world are welcome. We always have externs from Germany, but also from other places in the world. So we're very used to it. that people watching us working in the clinic. We're very used to speak English to externs, so that's not the problem. If you will find the clinic online, and you can just write some email to see if we are where we have available time slots for externships. So that's absolutely possible as well. Internships, we always have, I think, 7 or 8 interns right now, which they are running normally a rotating internship from either 12 or 18 months in the clinic, where they do the surgical stuff, the night shift, day shift, and rotating through all the different departments of the clinic. So yeah, we always have like 7 or 8 interns at the clinic. Of course, if you want to do an internship at our place, it's not necessary to be German speaking. We also had English speaking interns in the clinic, so that's normally also possible. But of course, we want you to make an externship first to see if you can then start your internship afterwards.
Thanks for the info. Another question, otra pregunta que escribió la doctora o estudiante Catarina. How long or how often would you change an orthopedic shoeing in a chronic laminitic horse?
Yeah. So the normal orthopedic shoeing cycle is 6 weeks. That would be the normal cycle. It depends a little bit on how fast the foot is growing. So normally, if you've got a good venogram and a good blood flow in the foot, and you put them on the clogs or on the safest shoes, so on a shoeing where the foot is constantly moving a little bit, you can reach 1 millimeter of growing full depth per week. So normally, when we send them home with the orthopedic shoeing or on the clogs, and they come back after 6 weeks, you've got 6 millimeters under the sole where you can work with. So the normal shoeing cycle would be 6 weeks. If you have a bad blood flow, especially on the sole area, sometimes the foot is not growing that fast. So then it's sometimes a little bit more difficult, but the normal shoeing cycle is 6 weeks.
Thanks. Can you repeat us what's the name of the journal where you're going to publish the case you mentioned?
So it's published in 7 languages. I think I don't know the Spanish name. So in the English name is the Farrier's Journal. I think in Germany it's called the Hoof. I don't know the other ones. You will find
In
them
the
on social
Farrier's
media as
Journal,
well.
people can find it.
Yeah, for sure.
Another question, feeding the laminitic horse, a
Yeah.
recommendation for diet.
So like we said, most of the horses do have a metabolic problem, insulin dysregulation, and most of them are simply too fat. So normally I put them on a straight hay diet, so 1.7 kilograms each 100 kilograms of hay. And normally the hay should be soaked at least 30 minutes in water. You could do more, you could do 2 hours at least, as well. So normally they get soaked hay 1.7 kilograms for 100 kilos. And then we just add some mineral feed, but no oats or something like that. So just hay and some mineral feed. That's what we normally keep them on to lose some weight. Like with these new drugs, the SGLT inhibitors, we will play around a little bit. We don't have too many experience with these because triglycerides will rise sky high if they pee out all the glucose. So everybody who's using that drug says, yeah, we measured the trigs, but they were high, but the horse did not have any problem with it. So for sure, with these new type of drugs, you will check your parameters more frequent in the beginning and see how much they can get from these drugs. So, but normal feeding is 1.7 kilograms of hay for 100 kilograms, soaked for minimum 30 minutes.
Thanks. Another question, have you seen or have experience with falls with laminitis, septic falls?
So Luckily, I have not seen too many folds with laminitic. What we see sometimes is if you have folds with a club foot and you put them on the shoes, these Dalma shoes or whatever, with the dorsal extension, and you do that in small folds and even enlarge your dorsal extension for the club foot, then you could create a mechanical failure of the dorsal lamellae. So you have to be a little bit careful with these dorsal extensions. They can create a mechanical laminitic in folds if you try to cure the club foot. But normally you do not get a septic get laminitic in septic folds. We don't see that normally. They are not heavy enough and they are lying on the ground a lot, so that's not the biggest problem for them.
Thanks. What is the long-term impact of laminitis on hoof biomechanics, and how does this affect the patient's quality of life?
Big discussion. How far should you go with your treatment? That's more an ethical discussion. So we saw a lot of horses which really severe changes with bad venograms, which were in the clinic for quite a long time, which recovered quite well. On the other hand, sometimes you see horses with not too big changes, and they are not reacting to your treatment at all. So sometimes these are really frustrating and tricky cases for sure. On one hand, so the treatment of a laminitic horses, in my eyes, should always be that the horse is, we call it like pasture sound. So he should be able to live a happy life without long time medication, run around in his paddock. For sure, not all these horses get back to work or get back ridden again. So you need a good communication with your clients about the best possible outcome for these severe laminitis cases for sure. And of course, also here we now and then have to euthanize laminitic horses. Sometimes there's no other or no way to save them for sure. Yeah, but there's something you have to talk to the owners quite intense in the beginning. If they say they just want the treatment, if the horse is getting fully ridden afterwards and can go back to jumping or whatever, sometimes you have to tell them that you should probably not reach that goal for sure.
Okay, another question. After surgery, do they walk normal or they are left with side effects?
So after that type of surgery, so this mare, I cut it the DDFT in September last year, and she's sound in walk. I just saw her yesterday, so she's walking in totally normal in walk. You can still see a little bit of swelling where the surgery was. You can still see that, but she's without pain medication, sound in walk. If you trot her, you can still see that she's 1 out of 5 lame on that leg, and she will probably stay lame on that leg a little bit. I mean, we cutted the tendon. So if you have a big tendon injury without any laminitis, the horse will be quite lame for a long time as well. So right now, I don't think that the pain she still has is coming from the foot, but more from the tendon injury now. Yeah.
Any experience with orthobiologics to help enhance the healing process in chronic cases or even in acute cases?
So I was playing around a little bit with PRP and an IREP, injecting into the coronary band and things like that. In my experience, there was no significant effect.
Thanks. And corticosteroids, injections in joints and laminitis. What's your experience or thoughts? Like
Yeah.
here, some people are afraid of triamcinolone and the horse
Yeah.
developing laminitis.
Yeah. So Yeah, the horses I see after injecting are most of them are treated with triamcinolone, and most of them in the coffin joints. That is the typical case for sure. I would not recommend to give any joint injection with triamcinolone or corticosteroids and fat ponies at all. So I've got a lot of normal orthopedic cases which are lame of different reasons, where I tell the owners that their horse is not a candidate for corticosteroid treatment. So yeah, we see the risk of laminitis with after injection of corticosteroids. A little bit different, it's with the systemic corticosteroid treatment due to breathing problems, lung problems, whatever. So, or inhalation with corticosteroids. We don't see a lot of horses getting a problem after these kinds of treatment. But joint injections, especially with triamcinolone, we now and then get laminitic horses due to that reason. Yes.
Okay. Gabapentin, do you have any experience? Is it available in Germany? What are your thoughts on this?
Yeah. So it's not too easy to get it in Germany. So it is available, but quite hard to get. So the people which are working a lot in pain medication and doing a lot of research in that area, they always said that you could use it. Me personally, I do not use it because most of the reason it's because it's hard to get it in Germany. What I use now and then is paracetamol. That's a drug I use now and then. But from the legal side in Germany, at least, you need to have a very good argument that you do not use the drugs which are licensed for horses and switch to a human medicine drug like paracetamol. But I've seen it in the US used and in England used as well. So that's something you could try as well if your bute or phenadine or whatever is not sufficient enough, but you don't have the chance to inject the horse with ketamine or butorphanol every 6 hours. So then paracetamol would be more the way I would try.
Thank you. And finally, one last question. Any recommendations to perform the standing tenotomy easier, better?
Again, like even better than described. So the way I described it is for me the best way to do it, or that is the safest way in my experience to do it. So you can do it in a standing horse, just in the stable. The horse can easily walk a few meters in the box afterwards. So just again, you have to. So I would always try a conservative treatment before I start a surgical treatment for sure.
Okay, thank you very much for your talk, Dr. Bjorn. It was great to get all this information. I'm sure for our students, it's really good. Thank you. Hope to see you next year in a practical course and meetings in Mexico City.
It was a pleasure. I hope you guys could get something from these lectures, and it would be an honor to come to Mexico and do some practical sessions.
Thank you.
Goodbye.
Muchas gracias a todos los que asistieron. Vamos a mandar una constancia por correo de la plática y nos vemos próximamente. La siguiente plática va a ser sobre dientes. La estaremos publicando en Instagram. Buena tarde, buen fin de semana. Adiós.